webinar. We also wanted to thank you for taking time out of your schedule today for joining us this morning. COVID-19 booster, preparing long-term care facilities and pharmacies. Though you will be in listen-only mode for the duration of today's webinar, please feel free to utilize the question box feature located in your control panel. We will do our best to ensure your questions are answered during our time together. Should you have additional questions, as always, please feel free to email covidtesting@age.ohio.gov. Again, covidtesting@age.ohio.gov. Additionally, a copy of this presentation will be forthcoming on the Ohio Department of Aging's website. And with that, I would like to turn it over to our Director of the Ohio Department of Aging, Ursula McElroy.
Thank you, Meredith, and welcome everyone to today's webinar. This 90 minutes is dedicated to addressing a series of topics related to COVID-19 and long-term care facilities, particularly assisted living facilities and nursing homes. Throughout, you will hear from experts in infectious diseases, pharmacy, post-acute, and long-term care. I hope you find our time together useful, and should you have concerns or questions that arise post-webinar, I encourage you to reach out for assistance. Today, I am joined by Dr. John Wigan, Medical Director of the Ohio Department of Health and the Ohio Department of Aging. Dr. Wigan has been instrumental in the COVID-19 pandemic response prior to and since accepting his dual role as Chief Medical Officer of both departments. He served as the Medical Director of the Post-Acute Regional Rapid Testing Partnership, facilitating testing support to congregate settings early in the pandemic, and as Chief Medical Officer of the state's Regional Rapid Response Assistance Program, or what we refer to as RAP. This is the state's COVID-19 strike team that was stood up to support long-term care facilities and providers. An accomplished medical director, he's experienced in assisted living, geriatric services, home health, long-term care, and wellness program for aging Ohioans. I am also joined by Kristen Dickerson of the Ohio Department of Health. Dr. Dickerson serves as the Chief of the Bureau of Infectious Diseases and is the state epidemiologist. She too has been instrumental in the COVID-19 pandemic response, and we are grateful that she is able to share her expertise with us today. Finally, we have a live panel discussion where you can ask questions with Alan Fox, a registered pharmacist, and Dr. Tom Leonard, Dr. Paul Sobel, both specializing in post-acute and long-term care. Special thank you to each of them for sharing their time and expertise. During today's webinar, we will do several things. We will examine COVID-19 vaccine schedules and vaccination coverage trends in long-term care facilities. We'll summarize the process to access and administer the updated COVID-19 booster, review updated CDC interim infection and prevention and control recommendations for healthcare personnel, and discuss best practice approaches to mitigate the effects of COVID-19 and other infectious diseases in long-term care facilities. And with that, I'd like to bring forward Dr. Kristen Dickerson.
Thank you, Director. My first update is going to be on the updates that the CDC just rolled out on Friday in terms of infection prevention in long-term care facilities. To level set everybody, the slide that you are now seeing is from the CDC's data tracker as of 9/25. IPC measures are influenced by CDC's community transmission metrics rather than the CDC's COVID-19 community levels. The community transmission metrics allow for earlier interventions before there is a strain on healthcare systems. Currently, 73% of counties in the United States are considered to be at the high level under this metric, including all of the counties in Ohio. Next, we're going to go over just a summary of the changes to the new guidance that was updated as of 9/25. Of note, there were updates to vaccination status. It is no longer being used to inform source control screening testing, or post-exposure recommendations. They have also updated the circumstances when the use of source control is to be recommended. CDC has also updated circumstances when universal use of personal protective equipment should be considered for use. CDC also recommended an update to the testing frequency to detect potential for variants or for shorter incubation periods, and to address the risk of false negative antigen tests in people without symptoms. They also clarified that screening testing of asymptomatic healthcare personnel, including those in nursing homes, is at the discretion of the healthcare facility. They also updated to note that in general, asymptomatic patients no longer require empiric use of transmission-based precautions following close contact with somebody with SARS-CoV-2 infection. They have also archived the interim infection prevention and control recommendations to prevent SARS-CoV-2 spread in nursing home, and special consideration for nursing homes not otherwise covered in sections 1 and 2 were added to section 3, setting specific considerations. They also updated screening testing recommendations for nursing home admissions. They also clarified the types of long-term care settings for whom the healthcare infection prevention and control recommendations apply. When SARS-CoV-2 community transmission levels are high, source control is recommended for everyone in a healthcare setting when they are in areas of the healthcare facility where they could encounter patients. As community transmission levels increase, the potential for encountering asymptomatic or pre-symptomatic patients with SARS-CoV-2 infection also likely increases. In these circumstances, healthcare facilities should consider implementing broader use of respirators and eye protection by the HCPs during patient care encounters. HCPs could choose not to wear source control when they are in well-defined areas that are restricted from patient access, such as staff meeting rooms, if they do not otherwise meet the criteria described in this slide, and community levels in their area are not also high. When community levels are high, source control is recommended for everybody. Testing is recommended for anyone with even mild symptoms of COVID-19, regardless of their vaccination status. Asymptomatic patients with close contact with somebody with SARS-CoV-2 infection should have a series of 3 viral tests. Testing is recommended immediately, but no earlier than 24 hours. If it's negative, they need to repeat the testing again 48 hours later, and then 48 hours again after that. So this will be testing typically on day 1, if exposure is day 0, day 3, and day 5. If you are implementing a screening testing program, testing should not be based on vaccination status. In nursing homes, individuals should be tested upon admission in counties where community transmission levels are high. At lower levels of community transmission, admission testing is at the discretion of the facility. Due to challenges in interpreting the result, testing is generally not recommended for asymptomatic people who have recovered from SARS-CoV-2 infection in the prior 30 days. Testing should be considered for those who have recovered in the prior 31 to 90 days, however. An antigen test instead of a NAT test is recommended. This is because some people may remain NAT positive, but might not actually be infectious during this period. The yield of screening testing for identifying asymptomatic infection is likely lower when performed in those counties with lower levels of SARS-CoV-2 community transmission. However, these results might continue to be useful in some situations when you're performing higher risk procedures or for healthcare professionals caring for patients who are moderately or severely immunocompromised, to inform the type of infection control precautions that are used, such as room assignment, cohorting, or PPE. It also can prevent unprotected exposures. If you're implementing a screening testing program, testing decisions, again, should not be based on vaccination status of the individual being screened. In most circumstances, asymptomatic healthcare personnel with higher risk exposures do not require work restriction. For the purposes of this guidance, higher risk exposures are classified as healthcare professionals who had prolonged close contact with a patient, visitor, or HCP with confirmed SARS-CoV-2 infection, and the individual is not wearing a respirator or a face mask if the person with SARS-CoV-2 was not wearing a face mask. A healthcare professional that was not wearing eye protection if the person with SARS-CoV-2 was not wearing a face mask. A healthcare professional that was not wearing all recommended PPE while present in the room for an aerosol generating procedure. In general, healthcare professionals who have had prolonged close contact with somebody with SARS-CoV-2 in the community, such as a household contact, it should be managed as described for higher risk occupational exposures as above. Work restriction is not necessary for most asymptomatic HCPs following a higher risk exposure regardless of vaccination status. Examples of when work restriction may be considered include the HCP is unable to be tested or wear source control as recommended for 10 days following exposure. The HCP is moderately or severely immunocompromised. The HCP cares or works on units with patients who are moderately or severely immunocompromised. The HCP works on a unit experiencing ongoing SARS-CoV transmission. If work restriction is recommended, the HCP could return to work after either of the following time periods. They can work after day 7 following exposure on day 0 if they do not develop symptoms, and all viral testing as described for asymptomatic HCPs is negative. If the viral testing is not performed, the HCP can return to work after day 10 following exposure on day 0 if they do not develop symptoms. The guidance and changes that were made by the CDC, CMS has changed their guidance and adopted this in lockstep with CDC. This is just the memorandums that initially went out for CMS. The next presentation that I will be updating everybody on is the bivalent booster recommendations for adults, and we're going to go over just some information about COVID-19 vaccines that you're probably all aware of in general. There are 4 approved or authorized vaccines in the United States to be used to prevent COVID-19. The Pfizer and Moderna are both mRNA vaccines. You can also get Novavax now, which is a protein subunit vaccine. Otherwise, you can get Johnson & Johnson, the viral vector vaccine in some situations. There are different COVID-19 vaccines, which now include our boosters that are recommended in the United States. COVID-19 vaccines are approved for people of different ages on different schedules. People who are moderately or severely immunocompromised have specific recommendations for COVID-19 vaccines, including boosters. COVID-19 vaccine ingredients are considered safe for most people. Pfizer is approved for 16 years and older, not just on an EUA, but on full FDA approval. In doing so, this was adopted on August 23rd. There was no change to the vaccine's formula, but it now has adopted a marketed name, Comirnaty. The same thing did happen to Moderna on January 31st, 2022. No change was made in the vaccine's formula. However, it has adopted Spikevax as its commercial name. On August 31st, 2022, the CDC endorsed the Advisory Committee on Immunization Practices, or ACIP's, recommendation for updated COVID-19 boosters. When the CDC endorsed this recommendation for the Pfizer bivalent COVID-19 booster for people ages 12 and older and the Moderna bivalent COVID booster for 18 and older, this recommendation then replaced all other boosters. And the CDC is recommending now that the bivalent booster is the booster that you receive. Clinical research has demonstrated the safety and effectiveness of the updated COVID-19 vaccines. With the arrival of the updated boosters, CDC is framing what it means to be up to date with vaccination. They are considering that you are up to date if you have completed your primary series and received the most recent booster recommended for you by the CDC. With the arrival of the updated boosters, like we said, the CDC is reframing what it means, and the bivalent booster is now replacing the booster recommendations for those that are 12 and over. The monovalent mRNA COVID-19 vaccines are no longer authorized as booster doses for individuals 12 and over. They are, however, still recommended for the completion of the primary series. Bivalent boosters are now authorized as single booster dose administered at least 2 months after either the completion of the primary vaccination series or the receipt of the most recent booster with any authorized or approved monovalent COVID-19 vaccine. Recommendations have been simplified. They are trying to change they're trying to change the dose counting from one bivalent booster for everybody that's eligible. If eligible, a bivalent booster should not be denied based on a total number of doses previously given to an individual. This is a pictograph. It gives you some information on when people are eligible for the vaccines. Again, the CDC is trying to simplify the booster process as much as possible. Once again, to be eligible for the bivalent booster, you have to wait a minimum of 2 months after the primary series is completed or a minimum of 2 months after your most recent COVID-19 mono booster dose has been received. For individuals with any immunocompromising condition, to be eligible for the bivalent booster dose, you have to complete the series including additional doses with spacing of a minimum of 2 months from the last COVID-19 vaccine received. The number of additional and booster doses previously received will not impair the ability to receive the bivalent booster. There does need to be that minimum spacing of 2 months since the last COVID-19 vaccine in order to be eligible for the bivalent booster dose. When we're talking about planning for bivalent boosters, it's very important to account for the fact that you're going to have to be able to efficiently vaccinate individuals within 12 hours after each file is opened. You do have to have the ability to manage both your primary series doses, so your monovalent, in addition to the bivalent booster doses in the same area when feasible. You have to continue offering your primary series vaccines for those that have not received their primary series, in addition to the bivalent boosters. You're going to have to continue to carry these different products throughout this fall. It would be best practice to review your COVID-19 vaccination records prior to vaccinating. If there is no available space on people's cards, you're going to have to complete an additional CDC COVID-19 vaccination card and staple both of the cards together. Sites should consider vial size and the expected demand when they are planning. Providers should be planning to continue offering your primary series again, and make sure that you manage inventory correctly, and make sure that you're trying to store your bivalent booster dose vials separate or indicate in a different colored box different from your primary series, because this does help to reduce any vaccine administration errors. We do continue to ask that you enroll as a COVID-19 vaccine provider. So any facility that is licensed by the Ohio Board of Pharmacy to administer or provide vaccination services is eligible to enroll as a potential COVID-19 provider. In order to successfully enroll in the program, you have to complete all required agreements and verification forms, meet program standards for vaccine storage and handling, and review or be familiar with training and requirements specific to the handling and administering of COVID-19 vaccines. We have a lot of information on our ODH Ohio COVID-19 provider enrollment webpage. Particularly pay attention to the enrollment checklist if you're interested, or the FAQ document. These resources are very beneficial to anybody in wishing to enroll as a provider. We do have a devoted team to help you enroll or answer any questions that you might have about administering or enrolling as a provider in terms of COVID-19. We are open from 8 a.m. to 7 p.m. The phone number is 1-844-9-ODH-VAX, and the email address is covidvaccine@odh.ohio.gov. A few important things that I want to kind of hit on in terms of storage, handling, and administration. Vaccines must be stored and handled properly from the time they are manufactured until they are administered to maintain the cold chain, thus protecting the potency and the effectiveness of the vaccine and ensuring vaccine recipients are fully and safely protected from vaccine-preventable diseases. All vaccines should be monitored and stored appropriately at all times. As part of the COVID-19 Vaccination Provider Agreement, providers are required to store and handle COVID-19 vaccines under proper conditions, including cold chain conditions and chain of custody at all times, in accordance with an EUA or vaccine package insert, the manufacturer guidance, the CDC guidance, in the vaccine storage and handling toolkit. You need to also monitor storage unit temperatures at all times using equipment and practices that comply with guidance that is given in the toolkit. Comply with immunization program guidance for handling temperature excursions. Monitor and comply with COVID-19 vaccine expiration dates. Preserve all records related to COVID-19 vaccine management for a minimum of 3 years or longer as required by the agreement or law of jurisdiction, and also comply with CDC instructions and timelines for disposing of COVID-19 vaccine and diluent, including used doses. In terms of temperature monitoring, the temperature of storage units containing COVID-19 vaccine must be monitored at all times with a temperature monitoring device. Vaccine should not be left outside of appropriate storage units for longer than it takes to prepare or thaw the vaccine for administration. Before your vaccine arrives, you will need to monitor the temperatures of your storage units to make sure that it will maintain proper storage temperatures required for the vaccine. Please see the ODH vaccine providers page under temperature monitoring and excursions for available downloads of printable temperature logs. Log temperatures and maximum of each day on the paper logs is required. When we're talking about transporting the vaccine, planning and preparation, you must pack vaccines according to the CDC storage and handling toolkit. Temperatures have to be monitored by a DDL during transportation. And make sure that you're not forgetting your ancillary kit if you have been supplied your ancillary kit. Vaccines cannot be left at a site without appropriate storage and temperature monitoring devices. Only prepare vaccines when you are ready to administer them. You need to store vaccines in their original packaging with lids closed until ready for administration. The vials and the manufacturer-filled syringes should always be stored in their original packaging. Loose vials or syringes may be exposed unnecessarily to light, which potentially reduces the potency of the vaccine, and it may make it more difficult to track for expiration dates. They may also impact inventory management and increase the risk of administration errors because they may be confused with other vaccines. When we're talking about monitoring the temperature after transport, immediately upon arrival at the destination, vaccines should be stored in an appropriate storage unit with a DDL. If vaccines cannot be stored on-site, in an on-site storage unit, they should be kept in a portable vaccine storage unit using a DDL to monitor the temperatures. CDC recommends transporting vaccines in vials. However, there may be instances where the only option is to transport pre-drawn syringes, pre-drawn vaccine in a syringe. The U.S. Pharmacopoeia includes guidance for transporting pre-drawn vaccine and syringes in the USP COVID-19 vaccine toolkit, operational considerations for healthcare practitioners. It is important to call ODH immediately upon discovering an out-of-range temperature. If you do this, place a sign on the vaccine that is in question, do not use, with the date and time and your name, so vaccine will not be administered by other staff members in error. There is a dedicated provider call line with the hours and the phone number on the slide that is there for you to answer questions and assist you. An ODH staff member will review your data and determine the next steps with you. You will need your temperature data and the temperature logs to send to ODH staff members if there is a temperature excursion. ODH will determine if a site must contact the vaccine manufacturers and help determine if vaccines are viable or if they need to be wasted. I'm going to give just a few updates on the flu vaccine because we are moving into the 2022-2023 flu season. This is the list of flu vaccines that are going out for the 2022-2023 flu season. The ones that are egg-based and the ones that are not egg-based do contain the same variants or lineages. There's 2 flu A's and 2 flu B's within each, and all are quadrivalent. Annual influenza vaccination is recommended for all people that are 6 months and older who do not have contraindications. All flu vaccines currently available in the United States, with the exception of the live attenuated influenza vaccine, are approved for ages greater than 65. 5 standard dose inactivated influenza vaccines. There is a 1 high dose inactivated influenza vaccine that is recommended for people that are over the age of 65 or those that are immunocompromised. This chart kind of breaks it down, what is available or recommended for ages and what is appropriate to be given based on your age. It also breaks down the type of the flu vaccine on the left-hand side. ACIP does recommend that adults that are 65 or over preferentially receive any one of the higher dose or adjuvanted influenza vaccines. There is a quadrivalent high dose vaccine, the HDIIV4. They can also receive the quadrivalent recombinant influenza vaccine, the IRV4, or they can receive the quadrivalent adjuvanted inactivated influenza vaccine, which is the ALLV4. If none of these 3 vaccines is available at an opportunity for vaccine administration, then any other age-appropriate influenza vaccine should be used. Ideally, vaccination should be offered by the end of October, but vaccination of those who have not yet received a vaccine for the season should continue after October throughout the season, as long as influenza viruses are circulating. An unexpired vaccine is available. Providers should offer influenza and COVID-19 vaccines at the same visit if the individual is eligible. This includes the adjuvanted or the high-dose influenza vaccines. They should be administered in separate limbs. With both influenza and SARS-CoV-2 circulating, it's very important for both vaccines to be given for the prevention of severe disease, hospitalization, and death. Getting both vaccines at the same visit increases the chance that a person will be up to date on their vaccinations. There have been studies that have looked at the co-administration that has shown that immunogenicity is similar for those who have received co-administered COVID-19 vaccine and seasonal flu vaccine compared to those who received the vaccine separately. Just for everybody's awareness, and because diseases in general are just starting to circulate again, with grandkids returning to school this fall, it's important that older adults also try to keep up to date on their vaccinations, because immunity from childhood vaccines can wear off over time. If you are at risk for you are also at risk for different diseases as an adult. Vaccination is one of the most convenient and safest preventative care measures that is available. It can help protect grandparents during those very important family visits. It's very important to remember that COVID-19 vaccine and other vaccines can be administered on the same day. And the final page is just, again, a way to reach us if you have questions about COVID-19 vaccine. You can call our provider line or email us. We can also point you in the right direction if you have questions about other immunizations for vaccine preventable diseases as well. And I think that was my last slide.
So thank you, Dr. Dickerson. I just want to spend a few moments on the vaccine maintenance program to be certain that you're up to date on how you can access the vaccine. Established in February of 2021, the program was designed to be a collaboration between the long-term care facilities and long-term care pharmacies and other community pharmacies. And while participation in this state-supported vaccine program is optional, there is still the expectation that every facility will establish a process for routinely vaccinating new residents, new staff, and those choosing to be vaccinated. And this certainly includes the boosters. As of today, 1,362 nursing homes and assisted living facilities have opted into the state's vaccine maintenance program. Nearly 163,000 doses have been administered through the program. That includes primary series and booster doses. Over 25,000 clinics have been completed. And as of today, the program has 34 active pharmacy partners. And I would like to take a moment here to extend our deepest appreciation to our pharmacy partners for all they've done to continue to ensure access to the supply is available for your residents and staff. Now, at the end of June of 2021, we asked all facilities to log back into our portal. We issued facility level login credentials, and those credentials help you to access critical information. If you have not yet logged in or you had trouble accessing the portal, as always, we would recommend that you reach out to us for assistance. What we are encouraging you to do is to validate your credentials yet again by Friday, October 7th. Now, essentially, once you log in, the validation process begins, and you simply will click on the green Start Validation button that will be displayed on your main menu. Please note that if you're on a shared campus, each licensed building must validate their own profile. The validation process will include reviewing your facility's overall profile, like the shared campus identification, making certain that we have the correct current contracted pharmacy provider, that we have updated points of contact, and also provide us with really important information regarding your level of participation in the state-supported COVID-19 testing and vaccine programs. Once the validation process has been completed, a confirmation email notification will be issued to the facility, and a banner will display on the facility's main menu. Additionally, you can view clinic details under the vaccine maintenance schedule button if you've opted into the vaccine maintenance program. As a reminder, clinics are coordinated directly with the matched or selected pharmacy provider. And finally, if you haven't gone in a while, the clinic details now show a 5th dose available for each vaccine product to assist with vaccine reporting by your pharmacy provider. So again, October 7th is an important date. We really want to get that information so that we have a clear understanding of what your plans are to be certain that we are within the facilities able to administer the updated booster. And with that, I want to turn this over to Dr. John Wigan.
Thank you, Director. So our last webinar was in June, and so I wanted to summarize the outbreaks of COVID-19 in our congregate care settings that have been monitored by the RAP team. And so I'm going to describe this based on the healthcare zones, and you can look at the map to determine which zone your facility might fall into. So Zone 1 is involves the Region 1, which is the Toledo area, Region 2, which is the Cleveland area, and Region 5, which is Akron, Canton, and Youngstown. And so looking at this over the course of the last 6 months or so, you can see that we had a spike really towards the beginning of September, and that has gone down over the course of the last several weeks in Region 1, which is once again the Toledo area. Moving to Region 2, you'll see a similar pattern, and this is going to play out pretty much across the state. We had a spike really pretty generally across the Cleveland area from the middle of the summer all the way, and then a little bit of an additional spike in September. And then Region 5, which is Akron, Canton, you can see we had a significant spike in early September, and that has fallen off in the last couple weeks. Moving to Zone 2, which involves the Columbus, Central Ohio area, which is Region 4, and then our southeast counties, which are Regions 7 and 8. You'll see in Region 4 that we've had a pretty consistent increase over the course of the first, across the summer until early September. It's had a steady decrease. In Region 7, we've typically been lower overall in Region 7 and 8. And I think you'll see in Region 8, we had a similar low pattern of outbreaks. Now, this is all self-reported, coming from facilities to their local health departments to the Department of Aging. So keep in mind that this is a relative levels, but it is what we use to call facilities. And then finally, in Zone 3, which is the Region 3 and 6, in the Dayton area is Region 3. You can see very similar to the other large metropolitan areas, with perhaps an earlier peak in late July and early August, with a steady decrease. And then finally in the Cincinnati area with a spike that really is very similar to Region 5 in early August. And so when you combine all this information into this graph, which is just a stacked bar graph, and if you think of Ohio, the north being green, the central being orange, and blue being the southwestern, part of the state, you can see that there's this increase and then a decrease depending on which zone, pretty much over the course of the last 6 months. The point being that COVID has continued to play a role in outbreaks within facilities across the state. And so we want to keep this on the top of our minds, and really this is the reason why we wanted to do this webinar to reiterate some of the importance of vaccination and other disease mitigation techniques, which we'll discuss now in the panel. So we have the Regional Rapid Response Assistance Program, or RAP program. This is going to continue, and you can log into the portal using to receive testing support, vaccine access, resources, and crisis staffing teams. You see on the slide the RAP team call center number. And you can also access that through aging.ohio.gov /RAP R3AP. So I'm going to ask our panel to go ahead and come on screen, and we can start our discussions. Oops, if I can. All right, I think that's our group. So I'm going to ask each individual to introduce themselves, starting with Dr. Lehner.
Good morning, everybody, and thanks for joining the webinar today. I hope this is informational for you. I'm the co-CMO for the RAP program, along with Dr. Jessica Coleman, and I also continue to be very involved in the long-term care and congregate care setting as far as my personal work.
Thanks. Dr. Sobel.
Hello, everyone. I'm Todd Sobel. I serve as the Region 3 Medical Director for the RAP program.
Excellent. And Alan?
Good morning. I'm Alan Fox, Pharmacist Advisor to the R3AP program.
That's a well-placed T-shirt behind you there, Alan. Appreciate that. And then finally, we've got, you already know Kristen Dickerson. I'm going to have her introduce herself through a question. I work with Dr. Dickerson at the Ohio Department of Health. And, you know, I know this is the first time that you've participated in one of these webinars for Ohio's nursing homes and congregate care facilities, and that you serve multiple roles at the Ohio Department of Health. Can you describe what's involved with being the state epidemiologist, and then also the chief of the Bureau of Infectious Disease? And then you can also introduce any other part of your background that you'd like to. Thanks.
So yes, as the state epi, each state and territory within the United States is a voting member of the Council for State and Territory Epidemiologists. So Ohio has one vote, and I carry that vote. So I work with Ohio Department of Health. There's other state agencies that might have information that I need in terms of position statements. So we vote on what is reportable. We vote on changing position statements, and this can include anything from infectious disease to overdose, what's reportable that way. Also environmental, sometimes environmental health, there's position statements that's related to that as well. As the state epidemiologist, I am involved in outbreaks, pandemics. I am, when Ohio requests help or assistance from the CDC, it has to go through the state EPI in order to engage with the CDC. I also am involved in clusters when it comes to suicide or looking at that and analyzing that. So anything that falls outside of the realm of one specific bureau in terms of epidemiology and their capacity, it usually involves the state epidemiologist. I also serve as the chief for the Bureau of Infectious Diseases. The Infectious Disease Bureau at ODH has a number of different teams. We have our HIV, STI, syphilis, our viral hepatitis group. There's a number of programs that are in that side of the house that report up through me, and so I manage all those programs. And we also have Orbit and our healthcare associated infections and all the EPIs that are in those programs, as well as our TB. We also have our zoonotic disease program, and we also have our vaccine preventable disease program, and that actually sits within immunizations. And the vaccine program also sits within the Bureau of Infectious Diseases. So all those programs are programs that I'm engaged with and that I oversee and that I assist with. And I work with some brilliant people, part of the BID team. In terms of background, I served in the military as a research tech with biomedical warfare. I did do a stint with the United States Public Health Service. I have worked the floor as a nurse in the ER. I have done rotations in nursing homes as a nurse. I've been an infection preventionist at a hospital, so I'm well aware of all the reporting requirements that infection prevention has to report through CDC. I also have served as a quality improvement coordinator in our ODRC within our rehabilitation center in the state of Ohio. I think I answered all your questions.
I think you did. That's an impressive resume. And, so I think you'd be a great person to pose this question as to where you think we are in the evolution of the pandemic and how it's also being pivoted to more of an ongoing endemic posture. Do you think that that's the case based on your experience?
So I think that the change has been, it's been coming, and the CDC is trying to step us through the processes of accepting the disease as more endemic. But just like with the flu that is now considered endemic, there's going to be periods and times where the disease is out there and it's more prevalent. And there's going to be periods and times where we don't see as much of the disease. And even with the shift in accepting COVID-19, SARS-CoV-2 as being something that's endemic and we're not going to be able to completely get rid of or eradicate, it is very important to note that we still have very high transmission level, and we're in that period of time that people are still being infected and hospitalized, and especially when it comes to those individuals that are more at risk for severe hospitalization and death, we really need to do all we can to protect those individuals.
Well, I guess given that assessment, how would you advise the audience to move forward in the care of Ohio seniors in the congregate care settings like nursing homes and assisted living facilities?
So the CDC does give metrics, and unfortunately, you're going to have to look at a set of two metrics, because you're going to have to look at the community transmission levels, because that will just dictate what you do as a healthcare provider. But you're also going to have to be cognizant of what's going on in your community and what your community level is showing, because that is what is going to tell you kind of what's going on specifically in your community. As healthcare providers, because the transmission is still very, very high, and every county in Ohio is still red when it comes to community transmission, there still is the very acute concern that there could be an outbreak and potentially it could lead to severe complications, death. And I don't think anybody that's sitting on this call wants to see something bad happen within one of our long-term care facilities. So it's still very important that we take the steps that we can to mitigate diseases, not just SARS-CoV-2, because we are going into flu season, and we are seeing an uptick in some diseases that may have been that we might not have seen. There was polio that has been found in the watershed in New York. And so with that, I just think that we need to, in general, be more concerned with the transmission of diseases and take whatever steps we can to protect the populations that are most at risk. And wash your hands.
Thank you. Dr. Sobel, so it's been described as this high plateau. In other words, we still have 200, 300, 400 deaths per day from COVID in the United States, which is, essentially like an airplane crash on a daily basis. How would you, I guess, do you have any general thoughts about that kind of continued high plateau as a medical director? So you serve as a certified medical director and some of your other roles.
So, I really want to stress the importance of vaccination, particularly getting the bivalent booster. Vaccination still provides the greatest protection against hospitalization, the severity of illness, including long COVID symptoms, and death. Throughout the pandemic, the coronavirus just rapidly mutates and more variants come across, and they're spread more quickly, and they evade our immune system. As discussed by Dr. Dickerson, the new bivalent boosters target both the original coronavirus strain as well as the Omicron, the BA 4 and 5. Vaccination and the bivalent booster is also still beneficial for patients who have a history of the SARS-CoV-2 infection. So immunity will start to wane over subsequent months after the infection has occurred. In addition, the vaccine is going to provide coverage for multiple variants that the patient may face in the future. It's also not too late to start the series. If you've not been vaccinated, obtaining the primary vaccine series is still very, very important. And it certainly would be the first step in protecting yourself and protecting the community as best that we can. Thanks.
I just want to jump in if I can. And
Sure.
As a pharmacist, I have one foot in the safe and effective area. And then with my public health role now, I also have the other foot in how to get things to people. And I just think it's such an exciting time that we not only so quickly came up with something that's safe and effective, but that we can also get it into the hands of healthcare providers so quickly. And as for the safety, the CDC reported on the vaccine adverse event reporting system, when 92 million doses of COVID vaccine had been given, there were no deaths attributed to the vaccine or the vaccination process. And we know that during that same period, there were several deaths reported, due to the infection. Even so, it's kind of disturbing that there's some employees or residents who are unwilling to consider Pfizer or Moderna vaccines for whatever reason. I'm kind of excited to report that since our last webinar, there's another option available, and that's the Novavax. Novavax is very similar to the way our traditional flu, hepatitis B, and whooping cough vaccines are produced and used. And it's just, again, can't stress enough how important it is to remember that the currently available vaccines have been shown to be very safe and effective against infection, hospitalization, and death.
Great. Dr. Lehner, you've been kind of quiet here. So do you have any additional thoughts based on this line of discussion?
Yeah, I do actually. And I think that we need to make sure we consider and keep in mind the influenza vaccine. We've been very lucky the last couple of years. We've only had a few reported cases each season of influenza, and it really hasn't had the magnitude that it had in the pre-COVID era. And that was largely due to all of us masking up and all the precautions we took to keep COVID at bay in our facilities. I've heard some comments about, well, maybe influenza isn't going to be a big deal because we haven't had it for the last couple of years. And I would argue that influenza is still a formidable virus, and it doesn't go away. It's an endemic as well. And I think vaccination against influenza A and B is critical to keeping ourselves, our families, and in particular our patients safe from another viral infection that could actually put them in the hospital and or end in serious consequences, including death. I would also recommend the high-dose quadrivalent influenza vaccine to protect our residents at the maximum level. So I think we're not done with influenza, and making sure that we vaccinate ourselves, our families, as well as our residents is critical this time of year.
Great. Going back to you, Kristen, I know you mentioned in your prepared statements, that the CDC requires or relies on this community transmission metric to determine, what infection prevention strategies should be used, like testing and PPE, what type of masking and those types of things. Can you explain why community transmission is preferable to community level, which is the metric used for the rest of the population, other than healthcare personnel?
Yes. The reason that the CDC wants to stick to community transmission levels when it comes to healthcare settings, long-term care facilities, is because these individuals are at higher risk. The community transmission levels is set up in a way that it is going to inform that there is a change sooner than just the community levels. And so why we're wanting to go with the community transmission levels is because it'll indicate that there is an issue. It'll be easier for us to identify and to pick up that there's an issue prior to there actually being an issue. It also really reduces any kind of strain that the healthcare environment would see, and it should in fact reduce any chances of outbreaks, just because you're trying to pick up increase in cases quicker by looking at the community transmission levels rather than just the community levels that is for the general population.
Thank you. So Tom, I know you serve as medical director in nursing homes, but also provide care in assisted living. And I think the CDC interim guidance has kind of separated assisted living facilities as not, necessarily using the community transmission guidelines. Can you give any thoughts on that decision and how assisted living should approach the next couple months going into the fall and winter months?
Sure. It was mentioned earlier on this webinar that it seems as though the pandemic is shifting more towards an endemic, and then grouping assisted livings along with the other congregate care settings like senior living and those types of living arrangements is really appropriate, and it does make sense. And there may be further guidance coming from the CDC for assisted livings, but whether or not that does in fact take place, there are certain things that haven't changed, and clearly the SARS-CoV-2 virus is a very highly transmissible virus, and fortunately it's become less virulent as we've gone through the last year for sure. But it doesn't change the fact that it does cause serious morbidity and sometimes mortality in the residents and the patients that we care for. So I think that doesn't change. And I think that we also know that in assisted livings, the visitation is a lot more liberal. Patients and residents come and go more freely. And so their risk in some cases may be higher than in a more controlled setting like a nursing home. So the vaccination and boosters provide substantial protection. And I would consider that we need to encourage the vaccination programs in assisted livings, just as we do in long-term care. I think it's a critical area of protection for our residents. The other thing we need to consider also is that the residents that live in assisted livings are there for reasons that they often can't manage their own care, not at the level of a SNF or a nursing home, but they're not able to manage their own care at home. They may be immunocompromised. They may have other chronic comorbidities that may put them at risk. So it would be good for assisted livings and other forms of congregate care that are similar to assisted living to consider other ways to mitigate the spread of the virus, masking, social distancing, restricting visitors and encouraging visitors that are sick not to take their loved ones out or not to visit until they're over their illness. And that doesn't just include COVID or influenza, but would also include the GI viruses that we see through the winter times. All of the residents are all vulnerable to all these illnesses, and they spread among the population in those facilities once they get started. So it's really important to manage those, all those illnesses the same. And once again, emphasizing the boosters and the vaccinations where it's appropriate can't be overstated.
Any other comments from any of the other panelists about assisted livings and maybe some of these other infections that we need to be concerned about? Okay. Well, Alan, as a pharmacist, I guess, can you speak to the role of the therapeutics that are available, the antiviral treatments, for example, or the monoclonal antibodies? Are those still useful, and are you seeing those being utilized in this population?
Absolutely. I see in both assisted living and in skilled nursing care the active use of the therapeutics, and I have to believe that one of the factors that led to the relaxing requirements from the CDC is the availability of these treatments. Paxlovid and bebtelovimab are both readily available and safe, effective. So we're meeting all those things that I discussed earlier. It's most important to remember, though, that the biggest challenge we have is early identification of disease. There's limitations to how long after you've been diagnosed that you can actually receive the medication. And so, per the CDC guidelines and common sense, the minute that somebody has a symptom, my allergies just got a little bit worse than they used to be, I have a little bit of cough and unfortunate bout of stomach distress, they should be tested so that we can make a good determination on whether or not they should be treated with the therapeutics available.
Dr. Sobel, I know you were instrumental in putting together a couple playbooks for the Department of Aging regarding therapeutics. Do you have anything to add about that before I ask you a question that's being posed in the Q&A about eye protection, so you can start thinking about eye protection?
Alan mentioned, as Alan mentioned, it is very, very important that we have these medications to be able to treat the infection. And that's allowed us to step back a little bit from some of the guidance. Fortunately, as an article from New England Journal that was just posted demonstrates, the efficacy of antibody treatment and the antiviral treatments are still very, very strong against these Omicron variants and the current infection that we're facing. So the monoclonal antibody, bebtelovimab, remdesivir, molnupiravir, and Paxlovid all maintain very, very good therapeutic use for these patients. That being said, patient selection is really critical. So not all patients are going to need to be on one of those medications. We want to select those that are immunocompromised, those that have multiple comorbid conditions, or perhaps those that had a very difficult course with a prior infection. These should be considered for these treatment options. And I do recommend, discussing with your pharmacist, doing a consult to review selected patients' eligibility and potential medication interactions with these medications. But that's all good news for us.
Got to remember the mute. So as I alluded to, there have been a couple questions regarding how there's been a change in kind of the wording of the eye protection face shield. And obviously, right now, Ohio's all red, so it really doesn't change things. But our hope is that that's going to go down. But the guidance regarding face shields, the wording is a little subtle. It basically says that facilities should use eye protection. Facilities should consider the use of eye protection. Granted, that's a subtle change, but how might surveyors look at eye protection at this point?
So it's a really interesting question. ODH has always maintained that the best practice would be that staff wear eye protection in areas of high transmission. The updated survey documents do not specifically address universal use of eye protection. However, typically when a facility does not follow best practices or recommendations and there's a poor outcome, it would be up to them to show the surveyor why the action did not contribute to the outcome. I believe ODH is working to get clarification from CMS related to updated guidance. And I know from talking with ODH that CMS has also indicated that surveyors should give facilities sufficient time to review and implement guidance, including updating policies and training the staff. Thanks.
Great. Dr. Lehner, want to talk to you a little bit about new residents coming into facilities and, what are the recommendations for isolation? Is it all of the new residents coming in, or?
I had to find the unmute button. Sorry about that. So really at this point in time, residents that are coming in to the facility, there's really there is no requirement to test or isolate asymptomatic patients at this point in time. However, patients that they're recommending you still have some access and wear source control for those that have recovered from a SARS-CoV-2 infection in the prior 30 days.
And can you also comment about the idea of screening vendors or staff members as they come into the building?
Yeah, so again, CDC has eliminated the requirement for testing of healthcare personnel regardless of vaccination status. However, the recommendations also state that they should testing individuals who have recovered from COVID-19 is not necessary if they're asymptomatic or if they've recovered from an infection within the last 30 days. Testing should be considered for those who have recovered prior to 30 days and in that 31 to 90 day window. And then, of course, staff with signs or symptoms, regardless of vaccination status, should be tested as soon as possible, and also should be restricted from the facility pending their results of their COVID-19 testing. I think that's kind of a common sense thing, but it also should be not sooner than 24 to 48 hours.
Here's a question, Dr. Dickerson, that I think you're uniquely able to answer. So can a nursing facility gain access to ImpactSys without being a vaccine provider?
If the nursing facility is giving vaccines and they're providing vaccines, then they could gain access to ImpactSys. However, ImpactSys should not be used to verify vaccine status. So it would be on a case-by-case basis. If there is the need for the nursing facility to go in and update vaccines that are given, if they are the ones that are indeed, in fact, administering, and they would need access to it, our team can work to provide that. But again, it should not be used because it is considered a patient's medical record. It should not be used to verify vaccine status.
Thank you. Alan, I'm going to ask you a little bit about the timing of giving the bivalent booster and influenza vaccine. Is that something that could be given together, or should they be separated?
As mentioned earlier in the talk, yeah, they can be given together. Once you have somebody ready to take their vaccines, it would be best to give both so that there's not a missed opportunity. Somebody leaves or goes out into the community from your congregate care setting, they may not remember that they have to get the other one. So we can certainly give them together, and that's encouraged.
Great. So here's a question. I'll open it up to whomever regarding kind of the testing strategy for somebody who's been perhaps exposed to COVID. How strict is that 1, 3, 5 day testing strategy? If they send out PCR testing and labs are closed on one of those days, is there some leeway in there? Any takers on that one?
I can try to field the question, and anybody else can jump in if they have additional information. Testing is recommended immediately, so as soon as somebody knows, but they do not want the testing to start prior to 24 hours. I think in terms of following the letter of the law, that is the most important thing that we follow. They would like, again, to have testing 48 hours out and then 48 hours out again. If it can't be 48 hours and 48 hours, going longer than would be seen better than going shorter than the 48 hours and the 48 hours. Just with the fact in mind that if there is a work restriction for some reason that they cannot return before the negative tests are received, and then also that they will not be able to stop wearing the masks in general until those negative tests are received because of the general guidance for quarantine and isolation, not quarantine anymore, but the general guidance in terms of being exposed to somebody with COVID states that you need to continue to wear a mask in all settings for up to 10 days. I think that answers the question.
One of the other important, one of the other important, and you may be getting ready to say this, Alan, is in terms of the timing of your treatment options. You essentially have 5 days from onset of symptoms to start either the antiviral or one of the monoclonals. So it is important to sort of have a timeline that you're able to follow and maintain. Alan?
It's exactly what I was going to say. So there's that. And then it also gives you time to reach out to the pharmacist to do the interaction check if you choose for Paxlovid. And also you can check the Liverpool interaction website that's mentioned in the EUA for Paxlovid for interactions if your pharmacist isn't available.
Here's a question. I'll ask it as it's written, and then perhaps we can talk about it in other settings. But will assisted living facilities be asked to routinely test staff who are not vaccinated? Dr. Lehner, do you want to take that one?
I think, again, they've relaxed the testing strategy based on vaccination status. So I think it would revert to, if you're asymptomatic, mandatory testing or routine testing is not recommended. If you have symptoms or have a history of a significant exposure, then testing makes sense. But as far as testing routinely, no, it's not recommended.
And is that the same for nursing homes?
Yes, it is.
Okay. Another assisted living question. Are assisted living providers allowed to make decisions regarding wearing of masks? Dr. Sobel, you want to field that one?
Yeah, so, it has been shown to be very, very effective wearing masks. The percentage of transmission wearing a mask is almost a 7% transmission versus 50-some percent if you are not wearing a mask. So, good infection control guidance is really, really important, and we want to protect our patients as best we can. And I think that's, choosing the type of mask. If you're in a setting, an N95 versus a regular surgical mask, that may be, up to the individual facility and what is the transmissibility rate, the community transmission rate that is occurring in your particular area at that particular time. That may be one of the ways to guide yourselves.
Thank you, Dr. Sobel. Dr. Dickerson, here's a question. Now I missed it. It just moved up. If a healthcare provider or a resident is symptomatic and they test negative using a antigen test, are they therefore considered negative, or do they need to test a day or two later? You're muted.
Yeah, sorry about that. So they're symptomatic and they had an antigen test. We would recommend that they actually have a NAT test and wait a day. Yes, just to verify.
And just for clarity, NAT test?
Sorry, the nucleic acid amplification test. So if there is a caveat. If they have had COVID and they're 31 days to 90 days out from having COVID, they should take that antigen test. And if they test negative, and if they test negative for that antigen test, we would take that. So there is a caveat depending on timing.
Okay. Any other thoughts about that? See another Impaxis question. I guess this is coming from an infection control preventionist for a facility. Why is it that we can't gain access to Impaxis if we're not a vaccine provider to be able to understand the vaccination status of our residents?
Because it is considered a patient's private medical information. They can share their medical history with their providers if they want to, but it's actually an agreement that every provider has to sign in signing up for Impaxis that protects that information. If you have the need to be putting in administered doses of vaccine, then we can work to assist you. But for there are no other needs in terms of looking patients up in Impaxis.
Okay, here's a question I'll throw out to the group, and we'll see who wants to answer it. Will this booster, and I assume this booster being the bivalent booster, serve as a one and done vaccine for somebody who's never been previously vaccinated?
I can take that. So in order to get the bivalent booster, you have to have completed your primary series. So they would have had to have the Johnson & Johnson or the 2 primary doses of the mRNA vaccine. So they will have to have received 2 vaccines or 3 vaccines. It's not just a one and done.
Okay. So the Johnson & Johnson is still available. That was another question. Yep. Also, the Novavax would be a primary vaccination option for that, correct?
So for the bivalent booster, it's Johnson & Johnson and mRNA. Currently, for the Novavax, there is not a booster recommended at this time.
Okay, very good. So mRNA, Johnson & Johnson, were our only choices for an initial
for the bivalent
series. Okay, great. Well, it looks like we're at the almost to the top of the hour, and I know Director McElroy wanted to kind of wrap things up. So, Director?
All right. Thank you, Dr. Wagon, and thank you to our wonderful panel. Just a few reminders to everyone. October 7th is the date that we're asking you to be certain that you go back in and update your credentials, essentially validate your profile. We're interested in making sure we have updated information so we can push out new information, new updates to you, but also so that we have some appreciation for what your plans are for this updated booster. If you have questions or need additional information, please check our website at www.aging.ohio.gov. You will find the updated guidance on the website along with this slide deck that will be posted. I'm really appreciative of our panel. I'm appreciative of all of you taking time to be with us today. And as always, we're here as your partners to help you to succeed. Take care, and we'll be in touch soon.